All right, welcome to our special board review explainer on non-small cell lung cancer. We're going to break down the latest guidelines into a super high-yield format, all designed to help you absolutely crush your boards. Okay, so here's our game plan. We're going to walk through everything from the initial workup and staging all the way to surveillance. We'll hit early stage, locally advanced, and of course, metastatic disease. Let's jump in. First up, workup and staging. You know, the fundamentals. Look, before we can even talk about treatment, we've got to master the workup and get a rock-solid grasp on staging. You've probably heard this a million times, but it is so true. For any new lung lesion, you have to remember two things. Tissue is the issue, and staging is everything. This really is the mantra in thoracic oncology. You can't make a single move, not one treatment decision, without a real diagnosis from pathology and a super precise clinical stage. Literally everything else we're going to talk about flows from these two things.
So for your boards, these 4 steps are totally non-negotiable. First, you get your CT of the chest and abdomen. Then, for staging, you're ordering a full-body PET CT and a brain MRI with contrast. Simple enough. Step 3, get that tissue, but do it in the safest way possible. And then, step 4. This is the big one, the one you can't afford to miss on a test. For any metastatic adenocarcinoma, large cell, or NSCLC not otherwise specified, broad molecular profiling is not optional. It's not something you do later. It's an upfront, day one order because it's going to dictate the entire first-line treatment plan.
Okay, TNM staging. I know it can feel like a beast, but please do not get bogged down trying to memorize every single substage. That's not high yield. For the boards, you just need to get the big concepts. For T-stage, yeah, know the key size cutoffs, 3, 5, and 7 centimeters. But honestly, the most important part is the end stage. You have to know your nodes. N1, that's ipsilateral hilar. N2 is ipsilateral mediastinal, and that's a key point because that can still be surgical. But N3, that's contralateral or supraclavicular nodes. And that, my friends, is what we call the kiss of death for surgery. That N1, N2, N3 distinction, it changes everything.
So this all leads to probably the most important question in modern thoracic oncology. A patient walks into your clinic, new diagnosis of metastatic non-small cell lung cancer. What is the single most important test you're going to order to guide their first-line therapy? I think you know the answer by now. It's broad molecular profiling.
All right, let's shift gears to early stage disease, stages 1 to 3A. The thinking here is pretty straightforward. Cut it out with surgery, then come in right after to clean up any leftover microscopic stuff with adjuvant therapy.
So the surgery's done, you got a complete R0 resection. Now what? Well, who gets adjuvant cisplatin-based chemo? This is super high yield. It's a category 1 no-brainer recommendation for pretty much all resected stage 2A through 3A patients. Now for stage IB, you might consider it if there are high-risk features, a big tumor, bad differentiation. But for stage IA, nah, we generally just watch those. The whole point is to zap any tiny cancer cells, the micrometastases, and bring down that risk of the cancer coming back.
But hold on, it's not just about chemo anymore. The modern era is all about hitting these cancers with adjuvant targeted therapy and immunotherapy. And I've got a great little mnemonic to help you lock in the 3 absolute game-changing trials you need to know. Just remember this phrase: all oncologists agree.
This is it. This breaks it all down. Let's walk through it. The first A in ALE is for alicatinib from the ALINA trial for ALK rearranged lung cancer. Easy, right? The O in oncologists is for osimertinib from the famous EDARA trial for EGFR mutations. And the final A in AGREE is for edazolizumab from the IMpower 010 trial for patients who are PD-L1 positive. You absolutely have to know these 3 pairings cold. It's a slam dunk for the exam.
Okay, moving on to locally advanced unresectable stage 3 disease. This is a classic boards topic, and honestly, the whole story here revolves around one single transformative trial.
For unresectable stage 3, one word just completely changed the game: Pacific. I mean, before this trial, what did we do? We gave concurrent chemoradiation, and then we just watched. And frankly, the outcomes were pretty dismal. The cancer would come back way too often. Pacific finally gave us something active, something effective to do after chemo and radiation were done. And this slide just shows you how huge that impact was. The before, concurrent chemoradiation and a median progression-free survival of about 8 months. The after, chemoradiation followed by 1 year of consolidation durvalumab. And look at that jump in median PFS, all the way to 17 months. We more than doubled the time before the cancer progressed, just by adding 1 year of immunotherapy. This became the new global standard of care overnight. It's a category 1 recommendation for sure.
Okay, so for the boards, what are the key points you got to know about Pacific? 1. The indication is unresectable stage 3 disease. 2. And this is a big prereq, the patient cannot have progressed on their chemoradiation. They have to be stable or better. 3. The drug is durvalumab, an anti-PD-L1 antibody. 4. The duration is up to 1 year. And 5. The super important exception. This does not apply to patients with EGFR or ALK mutations. We've learned that immunotherapy just doesn't work well for them in this setting.
Okay, we're now in the metastatic setting, and in this world, your first step, your second step, and your third step is always the same thing. Find the driver mutation.
I really can't stress this enough. For metastatic non-squamous NSCLC, broad molecular profiling is not optional. It is a Category 1 recommendation. You have to test for the whole panel. EGFR, ALK, ROS1, BRAF, MET, RET, the whole shebang. And why is this so critical? It's simple. Because if you find one of these drivers, giving a targeted pill is just so much better, so much more effective than putting that patient through chemotherapy.
All right, let's talk EGFR. It's the most common driver, so you really have to know this inside and out. For the common mutations, that's your exon 19 deletion and L858R, the first-line drug is osimertinib. That's Category 1, based on the FLAURA trial. But what about the tricky ones, the exon 20 insertions that used to be so tough to treat? Well, the game has totally changed. The standard now is amivantamab plus chemotherapy. And then you have some other uncommon mutations, but just remember they're often still sensitive to TKIs.
Next up, ALK rearrangements. Here, it's all about the potent next-generation TKIs. Your preferred first-line drugs are alectinib, brigatinib, and lorlatinib. For the boards, a key trial to remember is the CROWN trial. It showed that lorlatinib has just profound activity, especially inside the brain. And that's huge because the CNS is such a common place for these cancers to go. A drug that gets into the brain well is a massive win.
Now, ROS1 rearrangements. You can kind of think of this like ALK's cousin. The principles are really similar. The key is using a TKI that has great CNS activity right from the get-go. So drugs like entrectinib and repotrectinib are much preferred over older options. And keep an eye on repotrectinib. It's a key player to know because it works great in the first line and after other drugs have stopped working.
Okay, let's do a rapid-fire round for 3 more critical drivers. You see a BRAF V600E mutation, you give the combination dabrafenib plus trametinib. Always the combo. You see a MET exon 14 skipping mutation, the drugs are capmatinib or tepotinib. You see a RET fusion, the drugs are selpercatinib or pralsetinib. These are just must-know pairings. Lock them in.
But what if you do all that testing and the whole panel comes back negative? No actionable driver. What do you do then? Well, this is where your treatment algorithm makes a big pivot, and it starts to rely on a totally different biomarker, PD-L1.
So for these patients with no driver mutation, the backbone of their treatment is going to be chemo plus immunotherapy. But the exact recipe we use is guided by something called the PD-L1 Tumor Proportion Score, or TPS. You can basically think of it as splitting patients into 3 groups: the high expressors with a score of 50% or more, the low expressors from 1 to 49%, and the negative patients who have a score less than 1%.
Okay, this table right here, this is pure gold for your exam. It's the whole algorithm on one slide. If your patient has a high PD-L1 score, 50% or more, you actually have a choice. You can give pembrolizumab all by itself, thanks to the KEYNOTE-024 trial. But for everyone else, the 149% group and the less than 1% group, the answer is chemo plus pembrolizumab. This comes from the absolute landmark trial, KEYNOTE-189, which showed this combination works better than chemo alone, period, regardless of the PD-L1 score.
All right, we're in the home stretch. Let's talk quickly about surveillance, and then we'll wrap it all up with the absolute final takeaways you need to nail this on your exam.
So how often are we scanning these folks after treatment? Well, it really depends. If you have an early-stage patient who had surgery, you're doing a history, physical, and a chest CT about every 6 months for a couple of years, then you can back off to annually. But if they were treated with definitive radiation, or if they have metastatic disease and they're on a TKI or immunotherapy, well then the monitoring is way more intense. You're getting response scans every 6 to 12 weeks.
Listen, if there is only one number you remember from this entire explainer, make it this one. 12 months, 1 year. That's how long we give consolidation durvalumab in the Pacific trial for stage 3 disease. I promise you that is a classic test question. And here we are, the final takeaways. This is your checklist to ace the boards. Let's run through it. Metastatic disease, your first step is always broad molecular profiling. Early stage disease with a driver, You better remember Aedora for EGFR and Alina for ALK. Unresectable stage 3, the answer is always Pacific. Metastatic with no driver, the answer is Keynote 189. Worried about brain mets? Use the drugs that get into the brain like osimertinib or lorlatinib. And finally, when a patient on a targeted therapy progresses, you have to consider a rebiopsy to see what's going on. If you know these 6 points, you are in great shape.
And I just want to leave you with this final thought. Everything we talked about today, it's a snapshot. This field is moving so incredibly fast. These algorithms are already being pushed and reshaped by amazing new drugs like antibody-drug conjugates and our growing understanding of resistance. But by mastering these fundamentals, you're building the foundation you need to understand and use all the incredible innovations that are just around the corner. Good luck out there.